So patients who develop recurrence of a triple-negative breast cancer are somewhat limited in their options for further treatment based on the fact that they don't have hormonal therapy as an option and they don't have HER2-directed therapies as an option. And although we're eagerly awaiting more data beyond the press release for the Impassion study that looked at the use of a checkpoint inhibitor in the first line in combination with chemotherapy, we did get a hint that that is a positive study in terms of the primary endpoint of progression-free survival. We don't have currently an approval in that setting, and we're also waiting for additional treatments that are on the horizon, such as IMMU 132 or sacituzumab govitecan. At the present time, we don't have any targeted therapy for these patients, and chemotherapy is the only option for them. Fortunately, chemotherapy responses tend to occur at a high rate, but unfortunately, those responses tend to be short-lived. And so in an academic environment where access to clinical trials is present, these are patients that we prioritize to put on studies, and it's an area of high unmet need. In general, I would say that patients with triple-negative breast cancer don't go through as many lines of therapy, be it in the community or in the academic setting, mainly because of the fact that they have aggressive disease that tends to have short-lived responses. So when patients recur after an anthracycline and a taxane, as I mentioned, chemotherapy at present is the only treatment option for them. We take into account factors such as the burden of disease, how symptomatic the patient is, what toxicities they have from prior therapy, and their goals of therapy. We take all of that into account. Ultimately, we would want to get these patients on clinical trials, as I mentioned, because we really are very interested in looking at novel approaches for these patients in an area of high unmet need. In terms of the treatment that was given gemcitabine and carboplatin in the first-line setting, we tend to reserve combination chemotherapy for patients that are quite symptomatic, as this patient was. She had a cough and abdominal pain, and we know that these are drugs that she hasn't been exposed to in the adjuvant setting, and a combination therapy may be appropriate for her. In addition, we know that platinum drugs may be a particularly important treatment option for patients with triple-negative disease, perhaps even more important for those that are BRCA mutation carriers, but even in this case, I would say it is a very reasonable option in the first-line setting outside the context of a clinical trial. We were very fortunate to have the approval of a PARP inhibitor, an oral PARP inhibitor for patients with a germline BRCA mutation who have metastatic breast cancer, and this approval was on the basis of the Olympiad trial that was presented last year at ASCO. And in this study, women who had a germline BRCA mutation and, as you mentioned, had metastatic disease and no more than 2 prior lines of chemotherapy in the metastatic setting were randomized 2-to-1 to chemotherapy of physician's choice or olaparib. And in terms of efficacy, we saw about a 3-month improvement over chemotherapy with the use of the PARP inhibitor. And this treatment was generally well tolerated, and I would say better tolerated than chemotherapy, with less discontinuation due to side effects. And in general, the chemotherapy was also, or the olaparib, excuse me, was also associated with a higher response rate. So this led to the approval of olaparib for germline BRCA mutation carriers, and it represents an important movement ahead, or an important improvement, I would say, in treatment options. Unfortunately, these drugs are only available for patients with BRCA mutations, and as we know, all triple-negative breast cancer patients don't harbor a BRCA gene mutation, but for those that do, this is an important treatment that's now available for them, and I would say should increase awareness about the need to assess family history appropriately and to consider testing patients that we may not have considered testing in the past, and now that we do have a targeted therapy available to them.